Welcome to the Virginia Mason Institute quarterly webinar series, Building Lean Leaders. Our presentation today is how lean can support a healthy bottom line. Virginia Mason Institute provides coaching and education to organizations in order to transform healthcare worldwide. My name is Jamie Kahn, and as an Institute team member, I am proud to introduce our presenter today, Megan McIntyre. Megan is a faculty member at Virginia Mason Institute, and her in-depth knowledge of medication use processes, experiential training, program development, healthcare quality and safety, and regulatory compliance provides a solid foundation for an extraordinary client learning experience. In her previous roles with Virginia Mason, she has served as a clinical pharmacist, medication use quality manager, and director of pharmacy residency programs. She has led diverse teams in improvement projects in medication utilization, product procurement, and inventory and education design, and she has been an active contributor in several interdisciplinary committees. Megan is certified in the Virginia Mason Production System, also referred to as in this presentation as VMPS, and is also a certified professional in healthcare quality. Megan and I encourage you to ask questions throughout the session using the GoToWebinar chat or question tool. We will address questions during the live Q&A session following the presentation. Today's session will be recorded and posted on our website at www.virginiamasoninstitute.org. Webinar attendees will receive the recording and the question and answer document via email following this session. Thank you so much for attending. We're really excited to have you. And I'm now going to hand it over to Megan to begin the webinar, How Lean Can Support a Healthy Bottom Line.
Thank you, Jamie, for the kind introduction, and welcome everyone to the webinar. To get started, I'd like to just give a quick introduction to Virginia Mason. We are a not-for-profit integrated healthcare system in Washington State with 2 acute care facilities and 9 Puget Sound regional medical centers providing primary and specialty care. We have numerous clinical specialties and areas of excellence supported by a strong governance structure built around the Virginia Mason Production System. This is the pyramid. This is our strategic plan. The strategic plan is everywhere, supporting our work and decision-making as our true north, a compass of sorts. You would be challenged to find a team member at Virginia Mason who could not connect the work that they do to the strategic plan. The strategic plan was initially developed in the early 2000s, a time where there was intense focus being placed on the poor quality, unaffordability, and lack of access and transparency in U.S. healthcare, after the release of the pivotal report from the Institute of Medicine, Crossing the Quality Chasm. At this same time, Virginia Mason, for the first time in their history, having started in 1920, experienced financial loss for consecutive years, along with some other significant events. Out of a sense of urgency, our strategic plan was born, starting with the vision and philosophy of putting the patient first. This reminds me of a great Deming quote about survival is optional, no one has to change. And at this point, we chose to survive and also change. Throughout the development process, those involved came up with the concept of being patient first and put it on the plan. But we have a really great board, and at the time they challenged us to define what did it really mean to be patient first, and were we truly behaving that way, the way we were typing up in this draft plan that we were so proud of, or were we being more provider first or more financial first, which are all important to being around to providing healthcare. This certainly isn't to say that we didn't care about our patients, not at all, but rather we were still making some more physician-centric decisions. So after the work group, if they truly realized that they weren't being patient first to the extent that they thought, and then agreeing that yes, that was the direction to go, and making that strategic decision, that shift in mindset, we knew that we needed to find a method to accomplish this significant transformation for our organization. The Virginia Mason Production System was created after searching and not finding a comprehensive health management method to achieve our vision. The MPS is based on the Toyota Production System lean methodology and essentially involves changing a single keyword on the slide shown, moving from the customer is always first to the patient always first. These 5 philosophies or tenets of the Toyota Production System should seem pretty reasonable to you and applicable, whether we're talking about cars or patients. Here at Virginia Mason, we lead with quality. In the following slides, we'll explore more how the Virginia Mason Production System is helping us execute our strategic plan every day. I would like to challenge you, though, to reflect on your organization's strategic plan. Do you know what it is? Is it executed daily? By what method is it being pursued? If it's dusty and filed away on a shelf somewhere, maybe in a 3-ring binder, take it off and start a conversation with your leaders about it. To jumpstart you on this challenge, I'd like to do a quick poll of those in attendance. So right now, within your organization, about how many of your staff have a basic understanding of your mission and vision and can relate it to their daily work? Great. And just a quick look at the results, it looks like a lot of you have staff that are aware of your mission and vision, so that's excellent. That's sometimes one of the biggest hurdles to getting started. For those of you that think there's some opportunity there, it's certainly a place to emphasize and put some work and focus on. The second tenet of the Virginia Mason Production System is about highest quality and safety. This certainly is important when you consider executing on our strategic plan. In order to do this, we needed to define what quality meant to us at Virginia Mason. This equation defines quality as appropriateness times a good outcome, or the highest outcome, with a high level of service divided by waste. This is our version of the value equation that's out there that's simply benefit divided by cost. Originally, where we have waste as the denominator, we started with cost. But we really learned through deep study and consideration and experience that just like the Toyota Production System, the philosophy of economics is more about focusing first on highest quality through the removal of waste and not purely the reduction of cost. Lean does not stand for less employees are needed. By reducing costs in the traditional way, we and others would risk cutting too deeply and compromising our ability to provide a needed service, which certainly would affect our desired outcome for that product or service. I really like to bring up this equation as a way to emphasize the key components that should be considered when evaluating, improving, and delivering quality care. We certainly take pride in our medical outcomes, our international reputation for the Virginia Mason Production System, and our ongoing work to identify and eliminate waste from our processes. However, one part of the equation that's often overlooked by many healthcare organizations and is increasingly important is that of appropriateness. I'll share some examples later on about how we targeted this. So even if you can provide an outstanding outcome along with efficiency and great service, there is no quality if it was never needed in the first place. That's why it's a critical step when you're looking at achieving quality outcomes to know if a process, task, or an element of work is even necessary. And if it isn't, we shouldn't do it. The result of inappropriate care can result in significant harm to patients and certainly unnecessary costs. We've been applying this management method since 2002 and have seen some tremendous results in our efforts year over year, certainly with learnings along the way. This slide just highlights a few of them. We're particularly proud of our Top Hospital of the Decade award from Leapfrog for more than 10 years now, especially because it considers quality and safety and also being a good steward of your resources. I'd also like to draw your attention to the reduction in surgical instrument setup time. We'll go into this in more detail as a case example, but you can be thinking about this from a time savings perspective and also connection to OR performance. So what does an organizational focus on quality and safety look like beyond awards? It's really about embedding mistake proofing or error prevention into everything that we do. This takes on many forms, from workspace or process organization and utility, also known as 5S, to standard work, to devices, or other types of controls. All employees at Virginia Mason are empowered to be inspectors for safety and improvement opportunities. This is through our Patient Safety Alert System, or PSA. Our safety alert system is modeled after the practice at Toyota, in which each worker has the power to pull a cord, as shown here in the picture on the Prius line, to quote-unquote stop the line in order to remove defects by improving processes. There is a correlation out there in the literature that shows engagement in safety programs and financial performance, and we certainly have seen that here at Virginia Mason as well. This graph overlays the number of self-reported safety events from our employees through our PSA system, including those that are near misses or actual events really of any magnitude, against the number of claims filed against us. You might be noticing the punctuated decline in 2012, and this really shows the impact of an organizational initiative to further foster and deepen our culture of respect, which connects to our culture of safety and really led to an elevation in our safety reporting by staff. Here's another look at the financial impact of providing high-quality care, in particular here at Virginia Mason through VMPS. This graphic reveals that by focusing on eliminating waste and increasing quality, we were able to realize direct financial savings in our hospital liability program through the reduction in premiums. For a self-insured organization, which I'm sure many of you work for, this is a meaningful amount of financial resource. So consider your own organizational liability premiums and what a 10% change year over year might look like in terms of direct dollar savings and improvement on your balance sheet. So building on that, the final tenet of the Virginia Mason production system is to maintain successful economics. This slide here represents the total margin performance we've experienced over the last several years. Although VMPS cannot be named as the sole reason for all of this, it does demonstrate that our adoption of VMPS as our management method in the early 2000s has led to better organizational improvement as we deepen in our learning and commitment to this, especially around 2007, 2008, starting to see that increase. Like many of you, as a not-for-profit system, we need margin to reinvest in our organization and community. But if we exceed that budgeted level, we are able to give back to our staff through approval with our board. And this is in the form of a shared success program. Since 2008, we have met our stretch margin targets and been able to reward our staff. This includes maneuvering through the Great Recession, moving into our newly opened Jones Pavilion in 2012, which meant taking on more expense and depreciation, and you can see was a decline in budgeted margin. But those years we were still able to share back with our staff for their engagement and hard work in the form of a check. So the question of return on investment when implementing the Virginia Mason production system is often raised, and is probably a big reason why many of you are here today. However, there is not an easy answer that I can give you that people like, because we can't tell you the specific ROI, because we don't have it quantified. The Virginia Mason production system is a complex socio-technical system. It's our culture. It's how we do our work every day. It is not just a set of tools or project or something we do every now and then when it works out well. We can look certainly at individual projects or initiatives or focus areas to capture costs and savings, maybe revenue. But remember that quality equation and the fact that we're leading with quality and a patient-first approach, which means we aren't focusing initially or solely on just the money. That said, if we look at the same margin graph and think about the long-term benefits of growing and sustaining our culture, as well as some of the clear financial events, such as the liability premium reduction that I shared, you can see that our Virginia Mason production system and organizational transformation has most definitely played a role in our sustained economic performance. 2007 was the last year that we did not our budgeted margin level. At a high level, our transformation is about having a strategic plan and a vision that's used to align organizational resources from annual goals all the way down to individual employee performance goals. Virginia Mason executes on these cascading priorities via our management system in the world-class management model. I would now like to share some examples of how Virginia Mason has created these quality gains with financial success and a clear application of some of the lean principles. But first, a quick, really brief explanation of the foundational element of waste. There's a lot of other core concepts clearly that we employ, but we lack the time together today to cover in great detail. So waste. We should have counted how many times I've said the word waste already so far, but it really is key. Waste is defined as any task or item that does not add value from the perspective of the customer or patient. So it's really important that it's not us defining value, but rather the patients that are. Waste come in 7 categories defined by Taiichi Ono, one of the founders of the Toyota production system, and include things like time. We can all think about waste of time, of course, the waste of excess inventory, and the waste of overproduction I want to call out as it's considered the worst waste of all because essentially it generates all of the other waste that you see listed here and requires significant resource to manage this. So let's do another quick poll. I want to know about your thoughts on the 5S method and its impact on quality and safety. Great. Thank you for responding. It looks like a lot of you are familiar with 5S, and that's great. It is considered a foundational element and an activity of lean and is certainly key to several of the case studies that I'm going to share with you. I also want to do a quick introduction to it to make sure that if you aren't familiar that you have a baseline understanding. So 5S is a strategy that helps keep our workspace safe and organized at its simplest level. You can see here it's drawn in a circle because it does happen in a cycle and continuously. It starts with sorting, which is separating necessary from unnecessary, simplifying about creating a place for everything, considering point of use, building in sweep to make sure that things are returned to where they belong and that you're able to visually confirm you have all of your supplies or the pieces are in place. Standardization, both amongst the team that this will be the standard layout or process, and then finally the last S, which is self-discipline, admittedly the trickiest one to do, but the most important in terms of maintenance and sustaining those gains. So Virginia Mason Surgical Services, we have 3 different sites within our Seattle campus that perform surgery, different procedures, with 24 operating rooms, and we have about 18,000 patients per year that are served by our surgical services. Quite a few different specialty areas, a good-sized team, over 400, and this is an area where we do have some of our community partners that practice at Virginia Mason. So this is our surgical services vision statement. This was created by the team doing the work in alignment with our organization's strategic plan. It's focused around the patient experience and how to deliver high quality care effectively. And this drives and relates directly to their annual division priority planning. So here you can see their service priorities for 2015. It's connecting back up to the organizational goal elements on the pyramid, but then also delineate out the division's work. The example I would like to share relates to the Virginia Mason organizational service goal. Specifically for this department, it had to do with improving flow of surgical supplies and patients through the use of built-to-order surgical sets. A picture can really be worth 1,000 words. We build, or rather overproduced, instrument sets to keep the central supply shelves stocked, creating the need to use up precious real estate to store. We had to hire people to manage and move this inventory around, and even more people and materials were required at this time because it had to be reprocessed. So we take product all the way up to the OR, open it up, lay it out for a case, not use it in the case, and package it up, bring it back down, and then need to reprocess in sterile processing. So we were really good at adding instruments to these sets for cases, and that has existed for a long time, but we had no reliable method to review and remove unneeded or outdated items. So in 2013, our surgical services team approached the issue of instrument setup by challenging this status quo and applying Virginia Mason production system principles, specifically just-in-time, to work towards one-piece flow and also implementing setup reduction when considering getting ready for a surgical case. The outcome of this was the vision for built-to-order instrument set assembly. Attributes of built-to-order vision included providing surgeons only the instruments needed to complete the case safely and efficiently, based on direct usage data, and of course coupled with the system to meet any urgent needs. There was assembling the needed instrument sets just prior to use versus weeks to months in advance only to store. So this helped reduce storage and also the number of instruments needed because we weren't holding a lot of inventory. There's also an element of respect for people and removing the burden of work that I'll share more on. We started the built-to-order work by applying the principles of 5S, which again are sort, simplify, sweep, standardize, and self-discipline, to identify waste in the current process. The team identified in a few select ortho case sets a significant number of instruments, actually almost 60,000 of them, that were rarely ever used for a procedure. They did some math, and to make this meaningful, were able to equate it to almost 15 tons or 2 elephants worth a year of instruments. So now when you consider the physical burden of handling all these instruments, you can begin to see how this connects directly to the respect for people, our employees. So built-to-order eliminates the excess cleaning, assembly, transportation, and setup of these instruments and allows our team members to focus their work on other value-added activities, not processing 9 737 airplanes worth of unused equipment each year. This realization that all of the unnecessary handling and movement of instruments was adding no value to our patient's experience, remembering the patient, and reinforced the expansion of the built-to-order work in other surgical sections. Our team in neurosurgery has been a real leader in this work, and this is an example of the laminectomy case set. By applying the Lean 5S methodology in a successive fashion, the team was able to reduce the number of instruments in the laminectomy case set. First, they sorted out what instruments were actually used at the end of the case using the circulating nurse. Then, simplifying, removing again that unused equipment, but coupling this with the really important safety net of keeping an instrument if it was deemed critical for rare but emergent situations. Then designing a continual inspection of these case sets, or a sweep, which was facilitated by standardized tray layout, making it a lot easier to complete. Lastly, the team had an agreement and an ongoing monitoring process to ensure that the case sets remained functional and the instrument utilization was accurate. The standardized tray layout involved fewer instruments or items, which led to a quicker setup and less chance for error. So the laminectomy set went from 152 to 59 items, dropping the setup time from 24 minutes to just over 2 minutes. The team also compared pre- and post-improvement surgery times to ensure that these new limited case sets did not increase overall procedure time, say if we forgot something and had to go get it before we could start, and they did not find any increase. They've actually seen an overall decrease coupled with other improvement efforts. The team also created similar setup reductions with the craniotomy case sets, as well as deep brain stimulators, and then several procedures in other surgical subspecialties, such as general and thoracic surgery. I think you could say that the real gain and transformation of these instrument sets was the culmination of several formal Kaizen or improvement events that we conducted, but really constant daily focus by the team and the leader in these areas. This slide shares some of our internally captured process metrics, demonstrating the ability to reduce setup time for a case by removing waste and creating standards. In particular, we saw a reduction of about 42% for the laminectomy case. Applying lean methods of 5S is foundational, which all of you already, not all of you, but most of you at least captured that in the poll. And it's really important to conduct this activity and focus as you begin your work towards continuous flow without negatively impacting the surgical experience for the staff and patients. This was certainly our experience. While the captured laminectomy inventory decrease isn't huge in total dollars when you think about total expense or revenue in the OR arena, the time savings, the opportunity for increased OR utilization, and the more judicious use of resources to sterilize and store, it all begins to really add up. I thought it was pretty interesting to see that the minor sets, actually, the setup time was able to go from 19 minutes to 20 seconds. So a really significant gain in that area as well. So take all of this information and squint a little bit and start to extrapolate it and consider the magnitude of this change as we begin to move it to other sections beyond neurosurgery and orthopedics. The impact really becomes quite notable, and we are in the process of continuing to spread this throughout our surgical area. For more information, I encourage you to pull our recently published article on this topic, as it provides greater detail about the application of lean and our results. It highlights the impact to our staff, the power of engaging all of the stakeholders, and further demonstrates the financial impact of removing waste in this process. For this case study, we saw an initial savings of at least $60,000 in sterile processing expense. Again, think about multiplying this across additional surgical case sets. There are other cost savings that you can imagine. The biggest one, that is certainly the hardest to put a price tag on, is the elimination of errors due to instrument variability in a case set or missing instruments not noticed until a case was started, as there were so many items in each set, making it hard to inspect. Great. So next case example is on ambulatory care and creating flow in the primary care. So another quick poll I'd like to do to get a sense for what you think is the main reasons providers in your clinic or organization are not able to go home on time. Great, thank you. It looks like most of you are right on target, but they receive too many calls and messages throughout the day, which is great. So I'll be able to now share with you our story about how we've targeted this bit of work. Some additional concepts that we'll talk about during this case study are this concept of flow for efficient production and skill task alignment, especially when you consider direct care, time spent with the patient, and also indirect care, managing all that information related to patient care and the visit. Unfortunately, indirect care is not unique to Virginia Mason, which the poll certainly showed. There's an article from 2010 in the New England Journal of Medicine that set out to quantify the impact of these typical indirect care activities. They found for every visit there were at least 5 items outside of the actual patient visit that needed to be completed. So again, considering a typical appointment load for a provider in one of your clinics, and multiply out to find the amount of non-visit work they have to complete every day. A key step in the application of the Virginia Mason production system is to define the problem by going to the Gemba, or workspace, to actually see and capture the current state using our lean tools. This image is one way that we captured the movement of our primary care providers throughout a typical day. We paired it up with time of day along the top and locations and services along the left. This allowed us to see the impact of the indirect work, represented here by the green trend line that slowly builds throughout the day, on the provider's ability to take care of their patients. It also shows a large amount of walking back and forth between exam rooms and offices, but also the current state impact on having a healthy life outside of work. Our providers were spending upwards of 3 hours outside of clinic completing that indirect care. All of this erodes our providers' ability to deliver high-quality care and maintain the level of engagement and satisfaction that we know relates to patient outcomes. In the words of Yogi Berra, if we keep doing what we're doing, we will keep getting what we get. This really rings true for this case example. Our solution to breaking out of this primary care mold was to build a new process that supports continuous flow. So why is continuous flow so important? I've talked about it already in the previous example. In lean operations, we strive to achieve continuous flow because it is the most efficient way of turning materials into products or services. Fewer resources are required, and those that are used are optimized, leading to higher productivity, lower cost, and additional capacity within the process. Lead time is reduced, which increases access and service levels for patients, but also connects to a shorter money conversion cycle. Problems such as defects become more apparent quicker and can be corrected instead of remaining hidden within the batch, festering and often multiplying. Continuous flow also encourages communication between operators, which increases overall quality and value to those working and those receiving the care. This diagram puts the Virginia Mason production system concepts into a framework to achieve the departure to a new way of delivering primary care. The mortar that holds the blocks in place are the people aspects: leadership, change management, culture of respect, and ongoing training. The blocks are the methods to improve the clinic function, and the sequence here is critical. It again starts with 5S. Continuous flow is also called one-piece flow or make one, move one. Over the last several years, we have built a primary care model which is capable of meeting the needs of our patients, ensuring they have access to our services when they need them, but still allowing for growth of our primary care provider panels. By developing a model that allows Virginia Mason to improve quality access and growth, we are not only benefiting our patients and our organization, we're helping to lead the way in closing the quality cost chasm in healthcare. In a nutshell, we did this by removing non-value-added or wasteful tasks, moving around the work to the right skill level, having our staff work to their highest potential certification or licensure. In particular, the medical assistant, the clinical pharmacist, and nurse care manager. These roles have really been redefined and helped to level load the work across the clinic team. Another component to this transformation and optimization of the patient experience is removing batching of these indirect care tasks by creating a place, a physical place, and a process to go with it to visually sort and manage all of this work. This physical location is called a flow station, but it's not an inbox, it's not a break room or place to have your coffee or a dumping ground. It's a physical space where the medical assistant flow manager works to direct the provider and others throughout their day, ensuring the tasks are completed in flow. Moving all of the indirect care from the end of the day or at home late at night to in-between appointments helps to reduce the sheer volume of messages because questions or follow-up are resolved off the initial communication, not generating other follow-ups. Patient satisfaction was improved because they didn't have to wait as long for a response or for test results. And documentation and charging are found to be more accurate because they're completed proximal to the appointment when we know the provider's recall and accuracy are known to be higher. In one of our after improvement value stream maps, we saw additional outcomes in terms of reduced staff walking time, a reduced lead time for the patient rooming sequence, and particularly the work around the flow station. And a really important win was that we were able to create and implement additional touch points which really enhanced our patient experience with us. So did all of this work on improving flow make a financial difference? And yes, it has. This has been realized through less overtime. Providers aren't keeping their medical assistants late to help complete work. Certainly through better, more accurate coding and billing. We receive a lot less phone calls to follow up to see if they got the message or do they have the results, which means we need fewer staff required to man those phones so that those staff can then be redeployed to do other work. And there certainly is that relationship between patient satisfaction and increasing margins that's seen in other industries as well. Again, as in the built-to-order case study, we did some specific 5S events to improve the general internal medicine clinic supply inventories and also to standardize how exam rooms are set up to ensure that the frequently used items were available at the right time for our providers. This work focused things like walking, waiting, and frustration for not having the right equipment. And we also were able to see a reduction in our inventory carrying cost and the waste of having to toss expired supplies because we had too much in our supply. If you would like to learn more about how to move your clinic practice into more of a continuous flow model, we do offer an intensive course that teaches the lean methodologies necessary in a lot greater detail and actually allows for some hands-on work. This information is available on our website, and I encourage you to check it out. The third example I would like to share with you about how the Virginia Mason production system and lean methods have supported our quality outcomes and economic performance takes a different perspective, looking at the power of partnering upstream or externally with some of our employer groups who are the ones paying the really big bills for this health care for their employees. In 2004, we began working with employer groups after hearing them express their frustrations that resembled those of the Institute of Medicine report. Things like, the costs are out of control. We don't have a way to manage returning our employees to a functional status. There's a lot of delays, and they observed a lot of variability in terms of outcomes and costs between the different providers. So as such, we created the Marketplace Collaborative to define targets and specifications for us as a healthcare delivery system to meet the needs of our employer-payer groups. The collaborative developed a market-relevant definition of quality. There's a lot of different quality indicators out there, but we wanted to know those that were most important to those writing the checks for the healthcare. Several large employers worked together with us, and as legend would have it, within 30 minutes developed this list you see on the screen. Appropriate evidence-based care, 100% satisfaction, same-day access, rapid return to function, at an affordable price for both the buyer and the seller. These 5 specifications became the quality indicators by which we would judge the performance of the standardized pathways we designed. These 5 also led to the tagline for our work together of better, faster, and more affordable, and served as the end game for our work to build reliable systems by eliminating the waste of time, like absences and delays, and unnecessary care, getting at that issue with variation, and also the lack of defined best practice. The tools of the Virginia Mason production system, combined with the tools of evidence appraisal and best practice standard, allowed us to deliver the quality care that employers specified at mutually agreeable price. So I have 3 little snapshots of the VM Market Collaborative impact, highlighting quality outcomes and economics of medical care. The first one's around imaging. The second focuses on low back pain. And lastly, one on office breast biopsies. So reducing inappropriate imaging. A top expense for many employers is imaging studies like MRI and CT scans. especially the overuse of these tests, which unfortunately is encouraged to some extent by our current fee-for-service model. We have a published article with a lot more detail about how we reduce the cost related to these inappropriate studies that I encourage you to read. By using our lean methods of mistake proofing and building in quality, evidence-based decisions into the referral and ordering process, we were able to achieve a meaningful reduction in imaging. The mistake proofing tool, the snapshot there on the screen, is a piece of clinical decision support that's embedded into our electronic referral in our medical record, and it guides the best decision based on risk and evidence, and also provides data for actionable provider feedback about how they actually are ordering these, what types of patients, things like that, which allows for continued improvement. If one of the approved indications is not selected, they cannot actually order an imaging study. You'll see the reductions on the slide of more than 20% in some of the key areas. So the next example is our spine clinic. It certainly derives some of its success from the use of appropriate imaging that I just talked about. Back pain is a significant expense for employers and payers and comes with the additional cost of absenteeism or presenteeism, as well as decreased quality of life for our patients. We created a back pain clinical value stream, inclusive of the imaging guidelines and mistake proofing tools that I just shared. This has been a roadmap for our Kaizen work, leading to the creation of the spine clinic at Virginia Mason. It also met the 5 employer quality criteria. I do want to make sure to note that the clinical value stream maps emphasize reducing the cost of producing care. They need to be designed carefully, though, to ensure that the future state model contributes to the overall margin of the section in the medical center while still benefiting our patients. So before the spine clinic was created, a patient seeking care for their back pain would find a process designed with lots of waits and delays, weeks worth of them in fact. We were finding that they might wait 2 to 4 weeks for a visit, maybe with their primary care physician, hopefully neurology, neurosurgery, or physical medicine. If they did land in neurosurgery, they certainly would have an MRI ordered before the visit. Somewhere in there, medications would be provided. Hopefully someone would order a physical therapy referral, but again, there was a wait to get in for the actual evaluation. And then finally, the patient would have some physical therapy and likely provider follow-ups. Now, after the work that we did to achieve skill-task alignment and sequencing of the care experience, you can see that we were able to increase the flow so that all of this can take place in a single day, often with same-day access. This has certainly helped to reduce the time it took for patients to return to work, but more importantly, patients of the spine clinic are experiencing a quicker resolution of their discomfort. The new spine clinic flow is illustrated in this waterfall diagram. The MA is the blue bar, the physical therapist is red, and the doctor is the green bar. The flow of the appointment goes like this. So for the first 10 minutes, the flow manager rooms the patient, updates the medical record, and exits and signals the physical therapist, who then comes in for about the next 20 minutes, completes their musculoskeletal evaluation, sets the agenda for the doctor, and then signals the doctor for them to come into the appointment. The next 20 to 30 minutes, the physical therapist presents to the doctor with the patient in the room. The doctor does any subsequent examination, might review images if appropriate, and then the doctor, physical therapist, and patient come up with a treatment plan together. At this point, the doctor exits and goes on to see their next patient, while the physical therapist begins treatment with the patient for the remaining 20 minutes. A real quick business case can help answer some of the greatest concerns people have about this work. In particular, if we eliminate waste, that might eliminate revenue and reduce margin when you consider inappropriate imaging studies. The spine clinic operates at a much lower cost, which has allowed for a 4-fold increase in throughput with fewer FTEs. And after the employer that specifically we worked with this on directed the health plan to reimburse based on value, this value stream began to contribute favorably to the increased margin at Virginia Mason, offsetting any of the revenue loss that we experienced from less imaging. Here you can see that personnel and facility costs decreased by 29% and 78% respectively when we launched the spine clinic, compared to its performance in the traditional model of healthcare delivery. There were revenue increases where the doctor time is substantially reduced so they can see other patients and also have more time to see more complicated patients that often come with a higher reimbursement level. The net effect is that Virginia Mason improves margin, in this case more than 50%, while decreasing costs to employers. Finally, we look at the breast biopsy as another opportunity to provide quality care at an affordable cost to our patients and employers. This work served to identify the appropriate care for imaging using, again, the right clinical staff to perform screening and examination versus always a physician, and increase access for our patients, many who find the waits and delays for this experience to be quite stressful. We had a baseline wait of 16 days. Creation of a nurse practitioner-led clinic generated savings directly to our employers estimated at $316 per female, primarily from increased work productivity and also a decrease in direct costs related again to imaging and also professional fees. The patients coming in to have a breast biopsy or an abnormal lump examined went from waiting 16 days for some sort of information or resolution to 4 days, 12 days saved, which is meaningful, I think. We would all agree. There are fewer visits to doctors and surgeons and more ARMP visits, and the patients are certainly more satisfied. The surgeon is as well, as they're able to see more patients who actually need surgery or spend more time in the OR. I provided this citation for additional information and results on this work that we did as well on the slide. So in conclusion, I think we could safely say that Virginia Mason Production System has helped us develop and grow our culture, provides the method and tools necessary to reduce the cost of production and to deliver the highest quality care. Being patient first as we are has proven to be a sustainable business strategy, but our success is due to the ongoing investment in our culture, people, and management method. And with that, I conclude my presentation. There is opportunity to learn a little bit more. I've talked about some articles, citations. You can view some of our training and services as noted on the screen. We have a couple books that are great, providing more examples. And please do sign up to receive our emails if you haven't already, where you can hear more about upcoming webinars, case studies, etc. And with that, I'd like to open it up to some questions. Great. Looks like we've got a lot of really great questions coming in. So one of the first questions I think I'll answer, this was submitted in advance, so thank you for that. Someone had inquired about which specific topics or lean tools can be implemented and which area and topic is the best to choose for a pilot project. And my advice for you on this one is, at Virginia Mason we use it all throughout the organization, so we don't choose standalone parts. But much like when you would be approaching implementation of any sort of new thing, training or whatever, consider the level of human versus technical change involved, and think about where you could work to have small wins and gain some stakeholders, some champions, things like that. That's a really great question. We have another one here regarding, have we had to create a financial system to help those so that, have a direct impact on their work in a more transparent way? So we kind of redesigned our finances to connect to transparency. And we actually haven't changed our organizational financial system, but a big part of the Virginia Mason Production System is our daily management and application of Lean VMPS, which involves making our production capacity and demand and subsequent performance more visible so that we can really respond in the moment and make sure that we're able to, ensure access, outcomes, and if there's defects or some sort of abnormal situation, that we're able to respond to minimize disruption. Okay, we had a question where someone asked about defining budgeted margin as it relates to in slide 13. So this is about the amount of margin or profit that we have set at a level that we budgeted for in order to meet our commitments as a nonprofit. There also is a question about how do we deal with surgeon preferences for particular instruments. This may be hard to standardize, and you are exactly right, and that's something that we really had to work through. While standardization is really important, and we demonstrated that, there are certain pieces of equipment that we realized would be unsafe for us to standardize. When you think about the specialty and training that goes into using some of this equipment, we don't want to compromise quality or clinical outcomes by changing to an instrument that the surgeons aren't familiar with. But a lot of these instrument sets, contain equipment that's pretty universal. But if there was stuff in there that's outdated that no one uses, taking it out, that's really where to start. So 5S, again, is continual, so you want to continue to do it and look at it, but start with some of that easy stuff, that really visible waste to remove it. The other thing that we were able to do is engage our surgeons in this work. So having those champions really helped, and they could have discussions, compare. Maybe one of them actually had some advantages that they could share and train with the other one. So there was a lot of collaboration amongst the surgical teams. We have a question here about how do we ensure that all your staff are aligned with the strategic goals of the organization. That's an excellent question. And this is something that we continue to do, one, by making sure it's very visible, but building it in upstream has been really important. So if you're considering applying to Virginia Mason or speaking with one of us about a potential future career opportunity, this is the strategic plan and the Virginia Mason production system are going to come into those conversations, and we're going to start sharing what it's like to work here, what does it mean, to make sure that it's a good fit, because there's other healthcare organizations that provide excellent care, do great work, but maybe approach it in a different way. And if the Virginia Mason production system doesn't sound like something that would be a good fit for you, it might be really frustrating to work here. So we tried to start early on in the process. There's also a lot of opportunity for us to educate our staff and engage them in the goal planning process so that it's really clear. Oh, this is a good clarification. So I had said earlier on that we couldn't quantify an ROI, but then in one of the slides I talk about a $60,000 savings. So why not try to calculate cost and attempt to calculate a cost-to-benefit analysis? And I think that my comment about not being able to quantify the return on investment for the implementation of the Virginia Mason production system and the culture shift is that so much of it's intangible, or it's the soft things like culture of respect and safety, and how would you define something as VMPS versus not when it's really ubiquitous with how we do our work. So we do talk about savings because you're right, it's important to know, and that can be a really powerful message and way to engage people, especially if you're changing significantly how they're doing their work. But to put in the resources and attempt an organizational cost-benefit analysis would be a huge undertaking, and I think it would still miss kind of miss the true impact because of all those intangibles. Great question, though. So we have a couple here about recommended ratios for our clinic assistants per physician than exam rooms per physician. And this one I think is probably better to kind of discuss amongst your team and also understand if there's some sort of state regulatory requirement that might limit how you set up your physician structure. So that would be my recommendation as to where to start. And then also really understanding the flow again, and spending time observing their current state would be important to know what other work are they doing, because depending on their licensure and what they're allowed to do in your system, they may be involved in additional work that would not match our setup here at Virginia Mason. Great. I think I've got time for one more question. Let me take a look at it. So there's a good question here about how do we enable our staff to activate the patient safety alert system. And with that one, it's really about making it easy and encouraging staff to use it and creating a non-punitive environment that surrounds it. So it can be done through a phone call to our patient safety department or online through a pretty quick web form that just captures really essential information. They're not anonymous when they report it. We do have a name on there because it's important for follow-up and good root cause analysis and things like that. But this isn't a tattletale system, or it's not something that gets you in trouble. And this just really comes down through leadership and reinforcement as an organization that we value the information that's reported there. It's also important when employees file these PSAs that there's a response regardless of the magnitude of it, and so building that in, and that's been something we continue to work and stress with our leaders. How can we do that, especially as you saw the number of patient safety alerts going up so much? How can we respond and act on those events that are submitted? So I think with that we are out of time. I'm going to turn it over to Jamie, and thank you again for your attention and really great questions.
Thanks, everyone. Thank you, Megan, for this wonderful presentation. We really appreciate your time today. We didn't get to all the questions, but we will be sending out an email to all the attendees with a copy of the recording as well as a question-answer document. We will answer those questions that were unanswered during the session in that email, so look out for that. Just wanted to thank everyone for attending, and as stated earlier, our webinar will also be posted on our website at www.virginiamasoninstitute.org under the knowledge base. Please, look out for additional events and coursework that we have throughout the year. We would love to see you and love to see you at our next webinar. We do these quarterly. Also, please follow us on Facebook, LinkedIn, Twitter to stay up to date on lean healthcare topics. Thank you again for attending, and have a great day.